Bismillah ar-Rahman ar-Rahim. Cyclophosphamide regimens or cyclophosphamide regimes. Oral cyclophosphamide is used in active vasculitis at dose of 2 mg per kg up to 200 mg per day. We will reduce the dose in elderly by 25% if more than 60 years and by 50% if more than 75 years, and in setting of renal impairment. Monitoring of cyclophosphamide will check full blood count and renal function tests weekly for first month, weekly for second and third months, and monthly thereafter. If white blood cells below 4,000 or neutrophils below 2 multiplied by 10 multiplied by 9 per liter, stop oral cyclophosphamide and restart with dose reduced by at least 25 mg. If prolonged white cell count below 4,000 or neutrophil below 2 multiplied by 10 multiplied by 9 per liter for 2 weeks, or severe white if the white blood cell below 1,000, we should stop cyclophosphamide and start at 50 mg daily when white blood cells recovered. Then increase to target dose weekly. And if white blood cell is failing or falling below 6 since the previous count, reduce dose by 25%. Pulsed cyclophosphamide is given if patients cannot take oral preparations using doses of 15 mg per kg, reduced for age and renal function. Maximum dose is 1,500 mg every 2 weeks for the first 3 pulses, and then at 3 weekly intervals. The lowest white blood cell count occurs 10 days after a pulse. Randomized studies has shown that pulsed doses given a lower cumulative dose than oral regimes, but there is no difference in remission rates between the two. If giving IV cyclophosphamide, patients should be well hydrated before and after. Before starting, we should give 1 liter normal saline, and after giving cyclophosphamide, we should give 3 liter per day oral fluids for 3 days, and we should give what's called MESNA, which deletes with urotoxic cyclophosphamide metabolite acrolein. Dose varies according to the cyclophosphamide dose and is available on product literature. So we will give what's called MESNA, which is the drug chelates with urotoxic cyclophosphamide metabolite acrolein, and monitoring, we should check full blood count and renal function on day of pulse or previous day. If white blood cell below 4,000, or neutrophils below 2000. Postpone pulse until white blood cell multiplied by 4 and neutrophil until white blood cells more than 4,000 or neutrophil more than 2,000 while checking full blood count weekly and reduce dose by 25%. After first pulse, check full blood count between days 10 and day of the next pulse. And reduce the dose of the next pulse by 40% of previous dose if white blood cell is 1 to 2,000 or neutrophil nadir half to 1,000. Reduce dose of next pulse by 20% if previous dose of white blood cells nadir is 2 to 3,000 or neutrophil nadir is 1 to 1.5. Thereafter, check full blood count on day of pulse or previous day, unless dose of adjustment when checked additionally at day 10.